All right. So what are complications of using the vent? We talked about complications of having the artificial airway. What are complications of having the vent? Cardiovascular system. We've talked about it 8,000 times. What can happen to your cardiac output? Decrease, right? Decrease venous return. PEEP increases that effect, right? Decrease preload. What's preload? The volume in the heart. So we're decreasing preload, decreasing cardiac output, decreasing blood pressure. What happens to these patients who are laying in bed all day and not moving around? What can they develop? Blood clots, right? They're already having compromised circulation. So what do we need to make sure they're on? Some kind of prophylactic, right? We've talked about this, the barotrauma. This is basically, and you don't have to write everything, the alveoli rupture, right? They open up. That air escapes into the subcu tissue. And those who listened to the chest tube lecture, there was the subcu emphysema. Have any of you felt subcu emphysema? It is kind of cool, I have to admit. It's like Rice Krispies. So you'll palpate the chest, and it feels like there's Rice Krispies underneath the chest. Don't we have one somewhere? Do we have an example of that in our lab? Oh, all right. I don't either. But it does. It feels like Rice Krispies underneath the chest. Yes?
I thought what's the difference between that and crepitus?
Crepitus is like like what? I'm sorry?
My knees creak in when I've been.
Yeah. It's like bone, not like air.
I thought you told us when you press the chest and you feel like the air pocket.
Did I say it wrong? If I said it wrong, I apologize. I apologize. Subcu emphysema. All right. Remember, non-compliant lungs are at risk because they can pop open. Sometimes they get a chest tube prophylactically. We've talked about the pneumomediastinum, and that's where, again, they get air into the soft tissue of the neck. You have to be careful because they can compromise the airway if it's too much. If it's just a little bit, it's okay, right? But if it's too much, it can collapse the airway. That's just reinforcement. I'm not going to spend a ton of time. Everybody's okay. The vulval trauma, again, lung injury because of too much tidal volume. Again, these are a lot of times we're ventilating a patient because their lungs aren't compliant. So we have to be careful that we don't have too much volume, right? Which is an amount of air that's pressed in there. And we don't have too much pressure. That's what's keeping the alveoli open. And it's the same type of thing. They fracture, they open up, air can leak out. We have to be careful not to hypoventilate these patients or hyperventilate these patients. So with hypoventilation, the vent settings aren't right? We might have leakage of air from around the tubing, so we're not getting enough tidal volume. There might be some kind of obstruction. So a lot of times when we're hypoventilating, right, decreased, they're not getting enough tidal volume. When we hypoventilate, what happens to our CO2? It gets high, right? CO2 is acidotic. They're on the opposite side, we can hyperventilate someone. And this is when the tidal volume is set too high. So not only is it the rate that they're breathing too fast or too slow, it's how much volume we're giving them when they breathe. So if we overinflate the lungs by keeping the tidal volume too high, what's going to develop? What's going to happen? We're blowing off CO2. We're giving a lot of oxygen. Blowing off that CO2, what's it going to do? Yeah, become alkalotic. Good job. Ooh. I guess I didn't write it there. Oh, yeah, respiratory alkalosis develops. The ventilator-associated pneumonia. This is a big thing. If your patient develops VAP, a lot of times insurances will not cover any of the treatment that your patient receives. So VAP is a big thing for hospitals because if the hospital will have to eat all the cost of an ICU patient. Can you imagine how high those costs are for that hospital? They won't cover any of it because we gave them the issue. So as soon as they develop a pneumonia, because they're ventilated and we don't do a good job, insurance says, on you, hospital, you created that problem and you clean it up. We're not covering it. Because remember, insurance companies insure the patient, not the hospital, right? So it typically happens after 2 days. And again, we don't do a good job hand washing. We don't do a good job keeping sterile technique. Maybe the patient, we don't help them, we don't teach them to cough and clear secretions the right way. Maybe the respiratory, the ventilator itself, right? They have the humidifier that's down at the bottom, and if fluid gets stuck, you'll see water sometimes collect in the tubing. And again, if you go to the vent workshop, they'll show you that. That's all increases the risk of infection. So to prevent that, we keep that head of the bed up, right? We don't routinely change the vent tubing because the more we disconnect and reconnect, the more chance there is that we're not going to use sterile technique and, introduce a pathogen. We need to wash our hands. We need to drain water from the tubing. That's different than the vent itself. I shouldn't say vent. I'm using the wrong terminology. It's different than the tube that you use and the tube that's to the vent. There's separate tubing for the humidifier that's not connected to that system, that is connected to help provide humidification, because we want the secretions to be nice and thin. That's where you'll see the water collection, and that's what you're going to empty. And I don't have an example to show you, but if you go to the vent workshop, they can show you. Or if the next time you guys are in ICU, ask somebody, ask to see, if you haven't done your float there yet, ask to see if you can see someone with a vent. Ask them what the humidification, where is that? There's sodium and water balances. They tend to retain fluid. If they're not having good cardiac output, is their renal system getting good perfusion? No. So they tend to have decreased urine output, sodium retention. Neurological. Be careful of any increased ICP. So we keep that head of the bed elevated to 30 or 45. We're in the home stretch, guys, I promise. And a lot of this, it's kind of reiterating, right? We've talked about all the reasons why Now we're seeing what we can do as the nurse to make sure we don't prevent any complications. So GI, what was the big thing we talked about? Their risk for stress ulcers. Then GI bleeds. Increases their risk for infection. Also increases the risk for becoming septic. We don't want to make our patients sicker. We don't want to prevent or cause more complications. We're trying to fix the problem, provide symptomatic treatment without making it any worse. They can get gastric dilatation. So we put the NG tube down, so we decompress that stomach because we don't want them to vomit. We'd already talked about that. A lot of these patients develop constipation. If we're going to have ICP issues, do we want them bearing down? No. Or if the patient's sedated, we're giving them a ton of sedation. What do you think's happening to their GI system? It's slowing down. Are they able to wake up and tell you my stomach hurts because I'm constipated? No. So you have to make sure there's been a bowel movement recorded. Nutrition. Do we wait a couple days to assess that, or is that part of our initial assessment? Yeah, we're going to assess it pretty darn quick. We're not waiting to start all this stuff. We're doing it early. A lot of times people forget nutrition because, again, we teach you guys to think ABCs, and that's what we want you to focus on is ABCs. But ABCs doesn't last for, the initial ABCs doesn't last for 24 hours. You do ABCs, and then you assess all that secondary. Those who listened to the lectures, primary assessment is those ABCs, right? Secondary includes more detailed vital signs and making sure their nutrition is going to be adequate and making sure that we don't cause any more damage. Musculoskeletal. You would be surprised. These patients who get on vents, they lose muscle so quick. So quick. So not only do they need good nutrition, they need early ambulation, and they need physical therapy and occupational therapy involved early. They lose, these patients, everyone's got that. They will lose how to brush their hair. After just a week, they won't be able to lift their arms high enough because they'll lose so much muscle mass because they haven't had good nutrition and because they're not using those muscles. So even passive range of motion is really important. When you go in and do patient care, move their arm up and down, get their legs going. You want to provide that. And you want to make sure if they don't have a PT or OT consult, you're calling the doc and being like, hey, I noticed that the patient hasn't seen physical therapy yet. Oh, they're vented. I was waiting till they're not. Nope, we're not waiting till they're not vented. We're going to get PT and OT involved quick. And you'd be surprised. My mom was still vented. This is how she did OT. My daughter would come in and they put makeup on each other. My mom could not brush her hair. She couldn't lift her arms to brush her teeth. She had lost so much muscle mass in such a short period of time. Mm-hmm.
I wasn't vented, but even when I was after my motorcycle accident, because I was bedridden, 40 pounds.
Yeah, it's really fast. So that's why nutrition is so important. The right amount of protein and calories, and making it different and fun. It doesn't have to be this therapeutic regimen. For my mom, she really got a lot of strength back just because we have the picture. I don't think it's this yet. I don't know if I have it in here. I don't think I do. My daughter, my mom was the first time she tried to put makeup on my daughter. It was up here and all over the place. And it was that fine motor to that was what the occupational therapist came up with. They're great at coming up with different things that we don't think about. So you'll think about them doing certain little exercises. No, for my mom, all it was that she could pick up the little eyeshadow applicator and put it on my daughter on her eyelid. To that, my mom went from barely able to getting her cheek to, and not even she was holding it like this, to holding it with a pincer grasp and putting it on the eyelid, to putting lipstick on. So it was little things, and she was still ventilated. They had her up walking around. They were super aggressive with it because they were trying to get her muscle strength and everything back. The longer you don't have it, the longer the harder it is to get back. So you want to be aggressive with these patients early on. Psychosocial needs, again, this is not just for the patient, this is for the family too. They have a lot of physical and emotional stress, especially when they start to wake up and we start to have some sedation trials to see if they're going to be awake enough to extubate. But they can't speak, they can't eat, they can't tell you how they're feeling, and they're scared and they're frustrated. They have all, like, family members. They're seeing all these tubes and machines, and the machines are beeping, and they're like, what's that? Is that okay? And it might be okay. So we need to educate these families, educate the parents or patients. You're going to hear a beep. This beep is okay. This means that your oxygen is good. But if you hear this beep, you may see a respiratory therapist come in. That's okay. That just means that the tubing needs to be checked. It may seem simple and stupid, but it's really going to be important because, again, if they're anxious, what's happening to their heart rate? It's up. So then their cardiac demand is going up. That means that their oxygen supply, the demand is going up. Are they already having oxygen issues? Yeah. So these little things are going to help the outcome of your patient. They need to feel safe. They've lost, they have no control. And you need to involve the patient, the caregivers in decision. Bless you. That was my mom and dad. So, you need to involve the family members as much as possible. My parents had been married for 40 years right before she got sick and passed away. So, and my dad was super scared. He did not like the medical field at all. He would sit in the back, the hospital that we were at, I'm not going to say it. The ICU, the bed sit, and then it's like a pole, and then there's actually some space behind the bed itself. And he would sit behind my mom, and he would sit with her cell phone, and every day he would come with her cell phone charged because he was like, she's going to want her phone when she wakes up. So, and that's, that was what's important to him, and he got scared anytime that things would beep. So, and the nurses didn't explain anything. So once I was able to tell him that sound is normal, this is what we're expecting, or that's not, it would calm him down a lot. It would make him, And then when she was awake, she just wanted my dad to be there, So, and it was hard to get around the bed for my dad. So we would have to position her in the chair so that they could hold each other. So you have to make, exceptions. You have to kind of work with the families to provide these needs because it's going to help them feel better. So what's a big complication? The machine becomes disconnected. The most frequent site is the tube itself and the adapter. So most frequent site, this becomes unhooked, right? So you got your tube and it becomes unhooked from the ventilator. Never, ever, 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 ever turn your alarms off. So many nurses, especially when you get in the ICU, you just hear beeping all the time, right? I don't know how many of you have done your floats and if you heard beeping. And so sometimes they'll turn the alarms off because they want them to stop beeping because either the patient's alarming because they're breathing against the machine or because their respiratory rate is 17 and the machine's set for 16. So they're minor, and so nurses will get annoyed because they feel like they're just coming in there all the time and pressing the same button. But if you turn that alarm off and your patient becomes disconnected from the machine and you're out of the room, you're going to have no way of knowing. And if they become disconnected from the machine, are they going to be getting any oxygen? No. So never turn your alarms off. The ventilator itself can malfunction. What is that poor hospital that lost power during the hurricane recently, right? And their generator failed to back up. I'm sorry. An ALF, yes. So they lost power. They had ventilated patients. So if the ventilator doesn't work, disconnect your patient from the ventilator and bag valve mask. They're not getting any oxygen. So if they're alarming, are you going to sit there and be like, oh, it's alarming? It's not the respiratory rate. No, it's not the oxygen. That's set good. No, it's not. No, you're not going to sit there and figure out what's wrong with the machine, why it's alarming. When you hear the alarm going off, disconnect your patient, bag mouth ask them, call for help. Somebody's going to come in and be like, it's alarming, they were desatting, I don't know what's going on, then that person can go get you another machine. That person can call the doc. But all the while you're trying to figure out the problem, your patient's not getting oxygen. So if you hear alarms going off, you're going to start bag valve masking, you're going to provide them oxygen, and then we can figure out what the problem is and fix it. It's the last slide. I know, it's a lot of info. There's Mexican food. Where?
Downstairs.
Oh, we have to hurry up then. Okay. Dr. D likes her food. Okay. So, pre-weaning. We're going to assess the patient. Are their vent settings good? Their FiO2 is low. We're listening to them. They have nice clear breath sounds. We've done these daily sedation, what we call vacations, where we decrease the amount of sedation they have, see how they're waking up. If we have been sedating them for a week, do you think it's going to take a little bit longer for them to wake up? Yeah, they're snowed. So we got to kind of wake them up a little bit, see how they're going to respond. A lot of times when they're seeing if they're ready to be extubated, they'll go ahead and turn the sedation off. Then they'll turn the machine off or turn it down and see if the patient can breathe on their own. Okay? And they'll do that for about 5 minutes, see how they do, turn the machine back on, turn the sedation on. Why we're weaning them? We do these spontaneous breathing trials like I was just talking about. And we're monitoring them for any signs or symptoms of intolerance. So if we have them intubated and ventilated, and their respiratory rate is 14, and their FiO2 is 21%, and they're satting 98%, and they're relaxed, and they're taking nice breaths, and then all of a sudden we do this spontaneous breathing trial where we decrease the sedation and we turn off the machine, and the patient's respiratory rate goes up a little, but they're still comfortable and they're still maintaining a good O2, then we're doing okay. They might have to work a little bit harder, or they might be doing, but they're okay. If all of a sudden they start getting diaphoretic, they're super restless or anxious, they start having some cardiac dysrhythmias, their O2 starts dropping, their blood pressure goes up, that means they're not tolerating that spontaneous breathing treatment. Are you going to continue it? A lot of times these are timed for 20 minutes, for 30 minutes, for an hour. If your spontaneous breathing trial is scheduled for an hour, after 5 minutes, are you going to be like, we have a whole hour to wait? No, you're going to say, this patient's not tolerating it. I'm hooking them back up to the machine, okay?
Would you call the doctor then?
Yeah.
And
And say, patient's not tolerating it, I'm hooking him back to the machine. Respiratory therapy, if they're doing spontaneous breathing trials, should stay in the room during that time or should be nearby. It's not and typically your physician will be, again, these are things that are done during daytime. If you work nights, you won't see a lot of this because there's not as much staff on hand. And if something goes wrong, it's going to go real wrong. And we want to make sure we have as much resources as possible. So you'll typically see this happen early. We're not doing this at 6 o'clock at night. We're not doing this you won't even see it normally later in the shift. Typically they want to do it first thing in the morning, give the patient a chance to see how they do. So the outcome, we hyper oxygenate them right before we're going to extubate. We suction, right? Because we don't want to have any secretion sitting right here that as soon as we deflate that cuff, it's going to go into their airway and aspirate. We're gonna deflate the cuff, because are we gonna rip this thing out and rub all the mucosa? I've seen it happen. So, and again, is that your job as the nurse, right? You won't be doing the actual probably extubation, but you can say, here's the syringe to decrease the cuff. Yes.
I want to ask you about the suction real quick. So if the patient has fluid on the outside of the cuff, but the endotracheal suctioning is inside the tube, how do you suction?
In the mouth.
So you go up, you can go down that far? I mean.
You're not gonna go, you're gonna get it, like this is probably where that's going. So you're sticking it right here. There's enough pressure from the suction that it's gonna get those secretions. And then you're gonna move at the peak of inspiration. When they take a nice big deep breath in, you take it out, okay? And again, if after they extubate, they develop any of those signs or symptoms, then we may be prepared to re-intubate. I always just get everything ready at the bedside. Murphy's Law. If I have it, they won't need it, right? We can give them supplemental O2. They may go, maybe they extubate and they're okay, but maybe they still need a little positive pressure, but they don't need to have an artificial airway. Maybe they just need a little CPAP. Maybe they need, so a lot of times we'll extubate patients from a mechanical ventilation with an artificial airway to like a BiPAP or a CPAP machine, because they still need a little help. But we've talked about a lot of complications, right? So is this something that we want to keep patients on a long time? No, because we have all these things that could go wrong, and there's a lot of things that we need to manage. There's not as many complications with something like a CPAP or a BiPAP. It's still providing that positive pressure they need, but they can be awake, they can be up walking around, we can, provide good nutrition to them, and we're not going to have all those complications. Or they may just do good on normal, oxygen. Did you have a question? Okay. All right. So I know that's a lot of info. Why don't you guys, you have any questions?